How about we test now? Oh, much better. Okay. Thank you, everyone, for joining Doc Talk, NorthBay Healthcare's Doc Talk Live. I'm just going to do a quick introduction and then turn it right over to Dr. Dhond. Dr. Milind Dhond is board certified in internal medicine and cardiovascular medicine. He's the medical director of cardiology at NorthBay Medical Center and a professor of medicine at UC Davis School of Medicine. He received the Program Director's Award in 1999, national award presented to him by Valentine Fuster, then president of the American Heart Association. Also, he helped develop some of the technology that we use now by doing the original research and development for these technologies. When you go to see Dr. Dhond in the office, it's easy to feel at ease with him. He translates complicated to understandable for everyone. He may even use car analogies to help you understand how your heart is working. When not at work, he keeps quite busy. He has 3 children, all on their way to young adulthood, and is a 3rd-degree black belt in jiu-jitsu and runs a martial arts school where he teaches jiu-jitsu and kundalini yoga, a type of meditation, not medication, meditation. Please welcome Dr. Milind Dhond. I'm going to turn off my mic and we'll turn it over to him.
Oh, hopefully you can hear me. So I'm going to talk today about COVID, mainly because there's so much of it in the news. And I just wanted everyone, at the end of this talk, really what I want all the people listening is to have a good idea of what COVID is, what the risk is, and what is actually going on in the hospital and in the country today, and have a good idea of, rather than having all this barrage of media stuff. And I said previously, which most of you couldn't hear, that I don't know about everyone else, but I'm getting 10 emails a day about COVID, and on my social media getting 300 links a day. So the talk's really going to be, at the end of this talk, you're going to know about COVID. You're going to know about its effects on the heart, and what you need to know if you have any kind of heart problems. So we'll just jump straight in. Just in case I forgot to say at the beginning, welcome everyone, and let's jump straight in. So this is the structure of COVID. It's what's called a coronavirus, which is you don't need to know this, but it's really a positive strand RNA, and it belongs to a family of viruses. Now, people are in a panic that this virus is new and no one knows where it's come from. These viruses, the coronavirus family, is very old, and has been around for a while. In fact, even when I was in medical school, I won't say how many years ago, but it's more than 30. We discussed coronaviruses. Now, COVID-19 doesn't mean it's the 19th version, as a lot of people, I've seen that on social media. It means it came out in 2019. So it stands for basically coronavirus from 2019. That's and that's what the structure looks like. It's got this membrane protein and these what's called a spike on the tip, and that corona just means crown. So whoever named these set of viruses decided to name them after a crown. As we said, it came out in 2019. It's from a family of viruses that everyone's probably heard of before. So there's the SARS virus, which was present a number of years ago, the MERS virus, and in fact, the common cold is actually a coronavirus. So the SARS virus, interestingly enough, the good thing for us in medicine and actually everywhere is that the SARS virus has 80 to 90% of the same genetic sequence as the current COVID virus. So there's a very good likelihood that they're related and they've come from the same place. And you might say, well, so what? Well, the good thing is the SARS virus came out 10 years ago, and so people have already been looking at that virus for the last decade in various virology labs across the world. And so there is a lot of information on the SARS virus. And since there's a very close genetic link, that's good news for us. So there's a basic timeline of what happened with the COVID. In December of last year, and this began in Wuhan, China, and the initial case, it's difficult to know exactly, but probably came out in late September, but really started taking off in Wuhan in October and November. In December of that year, China alerted the World Health Organization of this unusual virus that was affecting that province. By January the 7th, there was a confirmed case in France. The first death occurred in January the 11th, and then it spread to other countries in Asia. As you can see, mid-January, it was in Thailand, then in the Philippines. The initial doctor that diagnosed it, unfortunately, passed away from it on February the 7th. And then by mid-February, it had become a world pandemic. It spread to the Middle East, and here the first case came out, I think, in February. So the likelihood is, if you think about it, it's very easily transmitted, and so it probably came here before February. Is a good bet. So the coronavirus itself is, like you said, has been around for a while. These viruses go between species. So the coronavirus and the SARS virus are thought to originate in bats. There's sometimes an intermediate vector there. So in the MERS, the intermediate vector was a camel, and then the bird down there is the bird flu, and I'm not sure how, and there's some sort of marsupial that they eat apparently in China that's also thought to be the vector that carried it to humans. So COVID is, if we look at the transmission, there's two ways it's transmitted. There's a direct transmission and an indirect transmission. So the direct transmission is basically respiratory droplets. So if I sneeze, micro droplets go out from my nose and spread around the room, and somebody can inhale those droplets. Similarly, if I cough, actually, if somebody's in very close vicinity to me and I'm talking to them, there's a possibility that they would get some respiratory droplets as well. Now, the indirect route is, if I'm sitting in my office, I sneezed, the droplets would aerosolize in the room, and then they would land on my desk. If somebody came into my office, touched my desk, and then wiped their eye or put their finger in their mouth, they would have a chance of catching the coronavirus. So if it did land on my desk, the question then becomes, how long is it viable on that desk? So when researchers look at this, they give us roughly what's called the 90% virus inactivation numbers. And these things are not specific. There's a range for these things. So what that basically means is, if I sneezed and it landed on a piece of cardboard, as you can see in the slide, within 4 to 8 hours, 90% of that virus would be inactivated. If I was at home and I sneezed and it landed on my fridge, which would be steel, it would last for 12 hours. And similarly with plastic, it would last for 12 hours. Now, people are using like towels and paper towels to wipe stuff up. If it lands on a paper towel, it will last there again 4 to 8 hours. Coronavirus is also very susceptible to UV light. So if you were to put it in sunlight, it would be completely killed in 2 to 3 hours. So if you say you got exposed to somebody sneezed and then the next day you didn't feel well, some of the symptoms of having coronavirus would be shortness of breath, high fevers, vomiting, pneumonia, cough. In a few cases, people get diarrhea. It has the incubation phase itself, which is part of the problem with the transmission of COVID, is it comes in 3 phases. It has a 1-week incubation. So say I'm in my office, somebody comes in, they sneeze in my office, and I inhale the COVID virus. It will incubate in my body for about 1 week. So during that 1 week, there's a range of things that may occur. Most people will have no symptoms, which is fine, except in the last 2 days of that week, I may actually be contagious, even though I feel well. So after that period, or somewhere near the end of that week, the symptoms will begin, and they will be what we just discussed: the fever, cough, diarrhea, shortness of breath. Now, the good news is in 90 to 95% of people, that's completely self-limiting within 1 to 2 weeks. In a small percentage of people, so 5% of people, that's 1 in 20, will get a pneumonia. And 2% of people, that pneumonia will be very severe, and they will get severe respiratory distress, and in some cases, multi-organ failure. And that's hence, 2% doesn't sound like a lot, but if you take 2% of the population, that's a lot of people. So the risk factors for COVID, just so that people know, the risk factors, 2/3 of deaths are occurring in men. Age is also a risk factor, and pre-existing conditions are also risk factors. And then what I mean by risk factors is your risk of that progressing to something worse is higher if you're a man, if you're older, and you have any pre-existing conditions. So if we look at the mortality by age, and this data is from all over the world, it's from China, America, and Europe. So if you're in the 30 to 40 years old age group, the mortality, so your chance of dying after getting COVID, is 0.2%. So that equates to 2 out of 1,000 people. And as you can see, as you get older, 40 to 50-year-olds, it's 0.4%, so it's double. And when you go from 50 to 60, it almost triples from there. And the 60 to 70-year-olds, it's 3.4%. And here's the biggest problem. Once you're above 70, so if you're 70 to 80, that's 8% of those people will die from this condition. If you're above 80, your death rate is 14%. So that's the reason. So that's why people want all these measures. It's not because you're 20 or 25 and your risk is 2 in 1,000. It's because your auntie who's 80 has got a risk of 14%. So if you look at mortality for pre-existing conditions, and what this basically means if you already have these conditions, your mortality is greater. So if you have cancer, your mortality from this is 5.6%. Hypertension means high blood pressure. So if you have high blood pressure, you've got a 6% mortality. Chronic lung disease, so if you have COPD or emphysema or very severe asthma, it's 6.3%. If you're diabetic, it's 7.3%. And if you have any kind of cardiovascular disease, then your risk is 10.5%. So that's pretty significant depending on what your underlying condition is. So if we look, so I updated this. This is, you probably get a feed on your phone of these numbers. So this is the update from yesterday. So, and it looks at how many people infected and how many people have died. So in the world yesterday, 3.8 million people had contracted COVID and 260,000 people have died from it. And this is one time that we, in the USA, we don't want to be number one, but unfortunately we are. So the US has 1.2 million infected people, and 72,000 people have died from it. The next highest country is Spain with 250,000 infected, 26,000 deaths. Italy is 215,000 infected and 29,000 deaths. And my home country is 201,000 people with 30,000 deaths. If you think we're alone in this problem, there are 185 countries in the world have been affected by COVID, and a significant proportion of the world's population is currently locked down. So then, how severe is this compared to other conditions? So most people have heard of Spanish flu. So Spanish flu is a virus that came out at the end of World War I. It got the name Spanish flu not because it originated in Spain. It got the name Spanish flu because Spain was not involved in World War I and had the only working journalistic infrastructure. And so they started reporting these cases. And so in the US and other places, because the reports all came from Spain, they said, oh, it must be Spanish flu. But it's basically an influenza that went around the world that had a mortality of 2.5%. Ebola, which you probably heard of, is this virus that tends to spike every so often in Africa. That has a mortality of 40 to 50%. The SARS epidemic from a decade ago has 9.6%. Now, COVID has a range of mortality. It ranges with current reports between 1.4 and 3.5% is your likelihood of dying from COVID. The regular flu is 0.1%. So if you look at the comparison between COVID and the regular flu season that comes around, in regular flu season, 1 in every 1,000 patients dies from that. You know how we kind of blow that off and say, oh, well, it's just flu. But actually, it causes significant morbidity and mortality in this country. It just doesn't hit the headlines. So 1 in 1,000 patients dies from flu. And you can therefore see that COVID is several orders greater than that. Probably, I'm trying to do my arithmetic, it's 10 to 15 times more virulent or has a 10 to 15 times more mortality than the regular flu. So if you look at the actual numbers itself, how many people have died from these conditions? And part of this is not to create panic, but just to give some kind of perspective. So if you look at smallpox, so smallpox since is largely been eradicated from the world due to a WHO program of mass vaccination. But from 1900 onwards, 300 million people died from smallpox. The Black Plague or bubonic plague, in which our ancestors, European ancestors and worldwide ancestors had to put up with, killed 225 million people. Spanish flu, which is the flu from 1918, killed 50 million people. Ebola, which has that very high mortality, has killed about 11,000 people. As we discussed, COVID has killed about 250,000 people. The H1N1, which was present about 10 years ago, killed between 150 and 500,000 people. And this is worldwide. So, as we discussed, do you want to try and prevent this spreading? The measures in place are social distancing, and the current guidelines are 6 feet apart. There's a great emphasis on hand washing, cleaning surfaces with bleach and alcohol. And part of the reason for that is it kills the virus. The virus has a lipid surface, and lipid means like a fatty surface. If you put bleach or alcohol on the surface, it will kill the virus. And similarly with soap. There's also the use of masks, surgical versus the N95 masks. And if you wear a mask, you can and everyone's wearing a mask, the transmission can be reduced by up to 95%. I'm just going to go back there. So just so you have an idea about the masks, on the mask, there's surgical masks, and there's this thing called an N95 mask. So those masks basically have what's called a polypropylene mesh. And that's a little mesh in the actual mask itself that blocks the virus by physical measures, but also it has a slight electrostatic charge, which will trap the virus. If you look at studies, people have looked at this prior to this COVID epidemic, and a regular surgical mask has the same trapping ability as the N95 mask. The only difference is the N95 is slightly better because it has a tighter seal, whereas a regular surgical mask is loose fitting around your face, and so air can get in and out through the side bits and the top bits. In the hospital, if we're dealing with COVID patients, we would use an N95 mask because the regular mask is very useful. It's easier to wear, and you can wear it for long periods of time. That's what most people are wearing. So I'm going to talk a little bit about the treatment of COVID. So there is no proven treatment for COVID. It's a virus, and because it's new, there's no definite therapy. There's also no, when I wrote this, there was no vaccine. But since I've written this, so you can see how quickly things are changing. So earlier this week in Oxford, England, where they were researching the SARS virus from a decade ago, they managed to, and remember we said there's 80 to 90% genetic similarity between the SARS and the COVID. So they have started testing a vaccine in people earlier this week. There's apparently also a vaccine in test in China. So then on the treatment side, we come back to, are there any drugs for treating these patients? So there's no new development drugs, but there are drugs that are already in the marketplace. So there's a drug called Camostat, which is used for treating pancreatitis, which is inflammation of the pancreas, and it's developed in Japan. And basically what it does is blocks the entry of COVID into cells, and that's being tested. So all these trials are up and running with rapid testing to just see if these things work. And that's a trial ongoing in Denmark. Now, hydroxychloroquine or chloroquine is a drug that's been around for a long time. It's used in malaria, and it apparently blocks replication of COVID in cells, and it has an anti-inflammatory effect. And people don't use it currently. They still use it for malaria, but it's mainly used because it has an anti-inflammatory effect. It's used for patients that have rheumatoid arthritis. It has significant risk associated with using it. And when they've used it in preliminary data shows that it doesn't have a significant effect. But again, the problem with this virus is everything's rapidly changing, and so what we say this week might be slightly different to what's occurring next week. There's a medicine that's used to treat AIDS, and these are antiviral medicines. There's a combination of something called ritonavir and liponavir, and they're used to treat AIDS. They're currently being they block what's called the protease enzyme in COVID. There's favipiravir, which is a medicine that when you take it, metabolizes into a drug that goes into the COVID virus itself and inactivates it. There's a drug you may have heard of recently called remdesivir, which is already out and has been tested for Ebola. It inhibits replication of the COVID, and so far has been the most efficacious in clinical trials. And these trials are, just rapid assessment of these patients. So with heart disease, so if you look at heart disease and how COVID causes heart problems or lung problems or these symptoms, COVID enters the body through something called the ACE2 receptor. And this is not important, but it stands for angiotensin converting enzyme 2 receptor. So that receptor is present in lung, heart tissue, gut. So when the COVID enters, it lands on those receptors, and that is why you have symptoms of pulmonary problems, lung problems. You might have diarrhea. Might have upper respiratory problems because it's landing on those receptors and entering your system through that receptor. With people with heart, so we've also noticed that patients are getting elevation of something called troponin. Now, troponin is a cardiac enzyme, which means it's already in your cardiac muscle. Because your cardiac muscle has an ACE2 receptor, we're finding elevations of this enzyme. And it's unclear whether that's most likely just a slight inflammatory reaction to the enzyme. The other possibility is that sometimes these patients become very ill and you're getting slight elevation of this troponin because the patient is so ill, it's causing some stress on the heart. There's no current evidence. So when I say current, I mean as of this morning, that you are at risk for getting a new heart attack just by having exposure to COVID. You're not more likely to get heart failure. Having said that, though, you are at risk if you already have those problems. So if your heart function is already poor and you get a big dose of COVID and you become short of breath, you're more likely to not do as well. As we stated in that previous slide, your risk is 10% because of the pre-existing condition. Now, arrhythmias and cardiac arrest. So arrhythmias means an abnormal cardiac rhythm, and cardiac arrest speaks for itself. So there are a significant number of people where it can cause a cardiac arrest, and it's unclear if that is related to them becoming so short of breath that they just end up having a cardiac arrest. There's some evidence that COVID prolongs something called the QTC. Now, if you prolong the QTC, it's just a measurement in the heart of the electrical circuit. If it becomes too long, your heart can stop. So obviously that's a problem, and that is actually the problem with hydroxychloroquine. Hydroxychloroquine will prolong your QTC. So if you think about it, if COVID causes a slight prolongation of your QTC, and you then take a drug that causes even more prolongation of your QTC, you're at greater risk for cardiac arrest. Also, there's things like congestive heart failure. It's not known to cause congestive heart failure, but if you have congestive heart failure, it's definitely worse. There's an increased risk of thromboembolism, and what that means is getting a blood clot in your lungs or a deep vein thrombosis. Again, it somehow is affecting the coagulation system, and it's unclear exactly why that is. And some people think that that's due to development of something called a lupus anticoagulant, which is something that's already known, but really increases your risk of getting a spontaneous blood clot. So in terms of therapy, obviously just anecdotally, there seems to be some benefit if you're already taking a statin, which a statin is a cholesterol blocking agent. So something like Lipitor or Zocor, it's unknown if starting a statin would reduce your risk, but if you're on a statin, you have a reduced risk. It's worse, obviously, in smokers because you already have some problem with your lungs if you're smoking cigarettes. Now, the other thing that we also noticed, strangely, with COVID was that the number of emergency rooms worldwide has seen a massive reduction in visits. So there's a little paradox here. And in general, the heart attacks and strokes visits to the emergency room have dropped by 40 to 60%. And that's a paradox, and people have been wondering why that is. And actually, what it looks like, unfortunately, it looks like people are so afraid of coming to the hospital and catching COVID that they're having their heart attacks and dying at home. And similarly with strokes. So that obviously is a problem. So just to reiterate, if you're having chest pain, typical symptoms of heart attack would be chest pain. It's dull, it's central. It can radiate to your jaw, down your arm. You can have associated shortness of breath, lightheadedness, clamminess, nausea. It's not worth, your risk of dying from that heart attack is 100 times greater than your risk of dying from the COVID. So you have to look at the relative risk. If you got a 1% chance of dying from COVID, you got a 33% chance you're going to die off the bat from that heart attack. So you should just seek help. If you want to call 911, that's probably the most beneficial thing you can do. And then if we look to the future, there's several things in the future. The social distancing and the masks are probably here to stay for the near future. And near future, that means probably 4 months, 6 months. And really the only thing that's going to abate this problem is either a vaccine, which we discussed is in trials. So if the vaccine is tested on patients today, information about it will be available in 2 to 3 months to see if it really works. Remember we said most countries are doing social distancing. In Sweden, they are not doing that. They have decided that they're going to continue as normal, except if you're in the high-risk group, in which case you are going to stay at home and stay outside, mixing in with lots of people. Their rates are 2 or 3 times higher than the countries immediately around them. The rates of death. They're still relatively small, but they're not, what you'd expect, which is some massive epidemic. So their idea behind that is to do what's called herd immunity, which means if everyone gets it, at some point, the thing will peter out. And then we discussed a few things on the medical treatment, which is, remember I said that this is being updated every day. So I'll just give you a little update. There's an update in the last 3 days since I wrote these slides. So the little update on the treatment is that part of the problem, so we talked about being on ventilators. So people have found actually that it's better to try and avoid ventilating patients and actually keep them on oxygen. And you can use these pressure masks that just push air in and are not actually where you're intubated and on a breathing machine. And even if you let the oxygen run a little lower, those patients do better than if you sedate them and intubate them. And that's sort of hot off the press. If you keep the patients adequately hydrated, that's also been shown to cause a slight reduction in mortality. There's less kidney injury. And then recently they've also found that if you use steroids, early on you will get an improvement in the outcome. Paradoxically, some patients are dying because of a massive immune response that's occurring. Your body's fighting the virus, sending off this huge immune response that's then shutting down all your organs. So the odd thing there is there's also been tests of agents that block your immune system. And these things, the immune reaction has been called the cytokine storm. And there's a medicine called Actemra, which is, there's generic versions of it. It's an IL-6 inhibitor, basically. And when patients are in the cytokine storm, if you actually paradoxically suppress the immune system, they do better. And then in the long run, people don't really know, when people have looked, there's no long-term data, but when people have looked at patients that have had very severe COVID and been on a ventilator for a couple of weeks, there's a small percentage of those patients that, a month later or 2 months later are still very short of breath and still requiring oxygen therapy. There's also a small set of patients who have some cognitive abnormalities where they're not, we always say, the lights are on, but no one's at home. So where they're not quite themselves mentally, and that is also, and have a little bit of confusion, and that's been shown to last for several weeks. So the data on long-term sequelae of this is unknown. So that's basically the update on COVID and how it affects different organs, how it affects your heart, and how if you have these comorbidities, you have increased risk. The one takeaway I would say, that one thing that, from my viewpoint, my specialty, that bothers me the most is actually the reduction in heart attacks coming to the hospital, because that just means people are dying at home. If you look at NorthBay as of, I'm not sure about the update this morning, but if you look at NorthBay yesterday, there were 0 cases of COVID in the hospital. Tons of people have been tested around here. Everyone's negative. You're safer off if you're having chest pain or any of those symptoms coming here and getting treated than risking it at home.
Now we're going to answer the questions.
Okay.
So stop sharing.
Okay.
And close. Minimize that.
Okay, so I'm going to just go through some of the questions. So the question number 1 is, how does the coronavirus affect the heart? Please comment on 5 stages. 1, when a person tests negative but has serious heart disease. So if you test negative, you don't have the coronavirus, so it doesn't matter. It's not going to affect your heart in any way because it means you don't have the virus. And then when a person is declared positive but has no symptoms. So again, when you're positive but have no symptoms, it all depends where you are in that phase, which means you could be positive and still in kind of an incubation phase, and you might get better from that, or it may worsen, and then you might find that you're much more short of breath 2 weeks later. So again, the risk if you have serious heart disease, like we said, is significantly greater just for your overall mortality. It's not that you're necessarily going to have a heart attack. Hopefully that answered that. So when a person survives the virus, what happens to the heart? So like we said, there's no evidence that the virus itself will increase your risk for heart attack or heart failure. If you're asking me about the long-term data, there is no long-term data. So it doesn't look like it should cause a long-term problem, but we're only going to know in 3 or 4 months from now if there's a long-term effect to it. And so the question is the disease always fatal in heart patients? Like we said, that if you have very severe cardiac disease, you get the COVID virus, you've got a 10% mortality. So that's 1 in 10 chance. Next question is, I have a catheterization and maybe a stent or 2 at noon at NorthBay. I'm 78, feel great. Do I have to worry about coronavirus? Yeah, so as long as you feel fine, then, the thing is, you have to do measures to keep yourself safe. If you feel fine, then that's great. The problem with these things is, I'm one of these people that always believes you shouldn't worry about the sky falling on your head. So all you can do is what you can do. And that means doing the measures that reduce your risk. Wear a mask, which is huge. If I wear a mask, if I have it and somebody else doesn't have it, and neither of us wear a mask, there's a 70% chance that person is going to get it if we're in close proximity. If both of us are wearing a mask, you've got a risk of 5%. So that's a massive reduction. So just being sensible will reduce your risk. The next question, my son is 14 months old. He has, it says cognitive heart disease, but I think that's probably congenital heart disease. Difficulty swallowing. What do I think about? Are my ideas for quarantining him? Well, there's no such thing as quarantining, because the problem with this is it's not a what you're doing, what you described there, where you're keeping him at home and trying to minimize his exposure to outside people. And when you do expose him to outside people, you need to have a mask on that person and him, and then wiping down your surfaces, like we said, with alcohol or bleach, so that if there's any trace of the virus, you eliminate it. And he can go out in the backyard and do what he likes. There's no way of quarantining somebody, because the problem is, if someone said, well, this thing will be gone away in 1 week, I'd be like, well, just hide in your cupboard for a week. But we might be here in we're already 2 months in. This thing might be going on for 6 months. So we're not in this this is not a thing. You have to learn how to live your life with what's going on currently. I have an aortic aneurysm, 4.3 centimeters. Should I take more precautions in the general population? You don't necessarily have to. I mean, 4.3 is fairly small. You just want to do the measures we discussed. And then it says, can you speak about the risk of serious complications for someone who had a heart attack several years ago? Again, if you had a heart attack, you're stable. That's Colleen, hi. So if you had a heart attack, you're stable, you don't have heart failure, your risk is fairly minimal. So, you don't need to, you're probably at marginal, this is not science. So I'm going to say, I would think it's unlikely that your risk is in the 10% range. It's going to be much lower than that. So if you just keep yourself, doing the distancing and stuff, you'll be fine. For about 4 weeks in February. So this is a good one. Look, so 4 weeks in February, my husband and I became very ill. 5 days of symptoms. And did I get COVID? So that's a great question. So the COVID test that most of you people have is where you put a swab up your nose, and that tells you if you have COVID right now. If you had something in February, say for instance you had COVID in February, then the question is, that swab test is no use. You would need what's called an antibody test, which is, it looks at the IgG, which is if I get COVID and my body mounts an immune response, I'll test positive for the IgG. So the question is, would an antibody test be appropriate? So if you're asking me, I'm not an expert in infectious diseases, but it would be very, very helpful to know how many people have already had this and don't know it. And this is data that's not, these things are not totally validated, but the Stanford did a random test of IgG of just random people in Santa Clara County, and USC did a random sampling of antibodies of people in Southern California. And roughly, I can't give you the exact number, it's between 3 and 4% tested positive for the antibody who had no prior knowledge that they had any exposure. So it's definitely been around, and there are lots of people who have it. And you might say, well, what's the reason for doing, what's the reason we would test everybody? Well, the reason is, if we tested everybody, we might find that their mortality rate is not 1 or 2%. It might be, instead of 1 or 2%, it would drop to 0.5% or 0.4%, because you might find the denominator of patients that's actually been exposed to it is way greater than we believe. But that's a great question. Oh, by the way, the other thing is, you can get, I just saw yesterday that Quest, if you go, I don't have any shares in Quest. If you go to Quest, you can order an antibody for yourself, and you can just pay for it and get it checked. And actually, as long as you don't tell anyone, I did that yesterday myself. So. What do you think the number of COVID-19 hospitalized? Why do I think the number is so low in Solano? So there's several counties. The good thing for Solano is we probably had one of the first cases of COVID in this country. The first cases, I think, came to Washington, D.C., and then we had the first non-travel related case. And because we had that, it came into Vaca Valley Hospital. It set off the whole, we jumped on top of it in this county, and the public health officials in this county were right on top of it from the get-go. The other thing is, it's like we said, so Solano counties and Yolo County and the neighboring counties have relatively low numbers. So for us, I think that's because we were on top of it from the early get-go. But these counties, even though we live in sort of urban area, Fairfield and Vacaville is still semi-rural. You know, people are still spread out, and it's not like living in New York City where 2,000 people live in your building. So we were protected from it because of how the community is spread out.
There's a question over on the chat.
Oh, on the chat, okay. Is that how does our overall?
Can you treat yourself at home?
Is that from the top?
No, it's at the bottom, Susan. Susanna.
How does overall oral? Oh, can you treat yourself at home with medical assistance via phone or video from your doctor? So hopefully that means, can you do a visit? So what we've noticed in the clinic is there's hardly any patients showing up to the clinics, but that doesn't mean we're not doing them. What we're doing is doing phone visits or video visits. And what that means, that makes it safer for you and it makes it safer for us, because then we're not having hundreds of people coming through into the building and exposing ourselves and yourselves to potential risk. So the actual number of visits is the same if you count phone visits and video visits. It stayed roughly the same, but the number of people coming to the clinic has dropped off significantly because people are afraid to come to the clinic and the hospital. But you can still access healthcare. And I was always a skeptic, to be honest with you. When before this occurred, people were like, video visits are great. And I'm like, they're rubbish, you know. And actually, I think they're pretty good now. Having been forced to use them, they're actually quite a good system. So, is there another question?
Oral health. How does overall oral health figure in?
So overall oral health. So I presume you mean like mouth care and nasal care and stuff. Well, the virus gets in through your mouth, your nasal passages. So there's nothing that's been shown to reduce your, you know, so this is the other thing. You definitely don't want to wash your mouth out with bleach or anything else like that. So just doing regular, you know, dental hygiene and stuff, clean your, you know, brush your teeth, use a mouthwash, that's fine. Using the mask is going to be the key to reducing your risk, though.
Ask a question. There's another question at the end.
Is it? Is there another question?
Yeah, it says, sorry if you discussed this. I jumped on late. My 11-year-old son had a co-arc repair at 10 days, an open heart surgery at 4.5 years old, and another co-arc reduced a thickening and widened a valve. He is bicuspid and doing great. Any real precautions I should take with him?
Yeah, so then I think you know how you have to be more rigid about the precautions, which means when he's exposed to anyone, he needs to wear a mask. You need to really make sure you clean down all surfaces in your house, because his risk is going to be higher than a regular person's, even though he's a regular person, but somebody who doesn't have those conditions. But otherwise, there's nothing else. I would just make sure you're more rigid about it. And you know, we've all been in this in a couple of months, so you find that you walk around, your mask is in your pocket, and then so for him and for you, you have to be more rigid about it than what's happening currently, where people are kind of kind of fed up and have had enough of doing it. But the problem is, we're on top of for us here in Solano and really in Northern California, we're on top of it. It would be a disaster if we suddenly fell back and suddenly had a massive surge in cases, and then we'd really be sunk. So it's, the way it's going currently is perfect. So it's better just to follow the measures and be cautious, and then everything's going to turn out fine. So.
Another question came up. What is the latest on having immunity if you have antibodies?
Okay, so there's a, like I said, I'm a cardiologist. I'm not an immunologist or expert on these things. In general, if you have a viral illness, you're going to have a good chance of developing immunity to it, depending on your immune response. So if I get COVID, I don't have anything wrong with my natural immunity. I'm not taking any immunosuppressants. I should have a reasonably good antibody response. There's some kind of confusion about whether, in general, if you take COVID out of the equation, so that typically will give you reasonably good immunity. There's some reports of people getting reinfected. So, the problem with anecdotal data is you don't really know what that means. So that could just mean I got COVID, my symptoms were still in a phase where everything seemed good, and then the incubation period is a bit longer, and then 3 weeks later I got it again, but actually that was maybe the initial episode. So, or I didn't mount a significant immune response. So in terms of that, if a long period of time goes, which means if I get COVID now and I'm exposed and I get antibodies and I'm exposed to it in a year from now, it's possible that I could get it then. And the reason for that is the virus is going to mutate, and that's normal for viruses. That's why you have to get a flu shot every year, because the virus will change slightly, and so you might not have the same immune response. The COVID virus, again, I'm not an immunologist, but the COVID virus apparently mutates less than the regular flu virus. So that's good for us.
Another question came up at the end. Any ideas on how to introduce a face mask to a 14-month-old child?
No, I mean, I think that's a tricky one. I think, a 14-month-old child, so all I'll say is good luck with that. But apart from that, what I would say is everyone else needs to be wearing a face mask then in your house when they're close to the child. But otherwise, I think it would be very difficult to keep a face mask on a small child.
Any other questions? I've got one more that just came up. One more. Dr. Dhond, I just had my heart valve procedure. If I were to get the virus, how would that impact my heart?
Again, it's the luck of the draw on these things. So you could get it. It doesn't, having a heart valve replacement doesn't necessarily hugely reduce your risk as long as your heart function is normal. So then you would just be in the pot of people if you get, you would have slightly higher than the 1 to 2% risk, but probably not the 10% risk. It's not going to affect your heart directly, though. You might get a slight elevation of that troponin enzyme, which anyone else would get, but you should be the same risk as a regular person, but maybe marginally higher, but not the 10%.
We have another live video stream on May 28th, and it's on enlarged prostate, and Dr. Hurt Kara will be speaking on that. Otherwise, thank you everyone for being here. Stay safe. This will be a recording on our website. You can always go back and refer other people to see it. Thanks, and have a wonderful day.